talk is, I think, personally, one of the most interesting technological innovations that healthcare has seen with regards to bridging the gap, taking affordable and rural quality healthcare to the most remote parts of India with the least access. And to present and talk about that technological innovation, we have none other than Narayana Health, one of the pioneers in actually helping telemedicine reach the masses. The topic is healthcare delivery Jio'fied. I think we've talked a lot about Jio today. It's about breaking boundaries in healthcare access, and to talk about telemedicine, we have Dr. Anupama Shetty, who's General Manager, CSR, Narayana Health, and Ms. Ramya, who's DGM Marketing, Corporate Office, Narayana Health. I leave that to you. Thank you so much for being here.
Thanks, Gunsha. Good afternoon, everybody. I'm Dr. Anupama Shetty, and I come from the space of CSR. So you would be wondering what am I doing here, so telemedicine is one of the innovations which we use a lot in our outreach programs, and I just wanted to kind of essay our journey in the field of telemedicine. And Gunsha, we've outdone ourselves. We got 62 slides, so but we'll try to keep it crisp. That's a promise from us. So Narayana began our telemedicine program somewhere in 2001. Excuse me? Excuse me, how do I make this? Can you just... Can I just use this? Yes. Okay, I think there's some problem with the slides, but no issues. What I wanted to say was that we began our journey in 2001. This was when ISRO and the Department of Health and Family Welfare, at least in Karnataka, we took on one project, but similarly at the same time, Pan-India, ISRO had linked up with several regional hospitals, the specialty hospitals, and they connected, I think, more than 380 rural hospitals to these specialty hospitals for telemedicine. And this is how our journey began way back in 2001. Dr. Shetty himself was personally very excited, and as part of the telemedicine rollout at that point in time, we did more than 21,000 consultations. This is in the ISRO model. And then we had the Karnataka telemedicine project. The Karnataka telemedicine project, we connected to a place called Sarguru in Mysore, and there we connected to 2 district hospitals, Chamarajanagar, and there was another district hospital, wherein again we engaged in, so this is where the telemedicine, as you can see, that's Dr. Shetty there. And this is how the telemedicine console at that point in time looked. And it was way back. I mean, you can imagine now there's been a lot of advancement, but this is how it started those days. And this was NH managing the cardiac care unit through telemedicine. There was a lot of ongoing consultation which used to happen. It wasn't store and forward. It was more of a live, interactive kind of a telemedicine consult. And as is given, 21,000 cases were referred using this service. And then we had our Arctics here, Rabindranath Tagore Institute, which is again connected to Udaipur, Siliguri, and Bankura CCUs. It's still going on. In fact, 2 CCUs, we've stopped our consultations because, there is sufficient manpower there now to take care of their own issues, but we're still consulting with Udaipur. And these stats which I got recently was that 46,700 patients have availed teleconsultations, and 17,000 inpatients were in fact treated. And one of our most senior cardiologists, he still consults with the team there in Udaipur CCU. So this is Udaipur, that's a district hospital, sir. So this was connected with district hospitals. Government hospitals, yes. So this is all part of our outreach. Everything was free. And then we had our tele-ECG network. So tele-ECG was a very specific service which NH rolled out. We developed our own model, so to speak, along with Schiller, and this was called the trans-telephonic ECG model. It was an older model. Now we've gone on to more state-of-art mobile health kind of based platform, but way back those days, this is in 2005, we kind of introduced the Schiller tele-ECG, TT-ECG. We gave out free to GPs and other diagnostics labs, and this was across Karnataka and several places across in India. In fact, 1,000+ centers are empaneled with us. We evaluate almost, it's around 700 to 800 ECGs a day. There is a 24/7 panel of cardiologists who are assessing and evaluating, interpreting the ECGs, and I believe we've done more than 9 lakh ECGs till date. So this is still going on. This is a very robust platform, but what we realized is that there's no cloud-based data, in the sense we are not able to do further analytics on it. We knew that we needed to move out into more mobile, into a more kind of responsive and responsive medium, and so we have gone on to a mobile health platform. So we've gone, and plus, while working in the outreach areas, we realized that we needed technologies which was also suitable for a rural setup, a battery-operated kind of device, and which should also, and the doctor also wanted to move away from his computer onto his mobile. So which is why we've been looking and exploring. There are several technologies, but yes, we've taken on a couple of vendors. 12-lead ECG itself, ECG is stored on the mobile tablet as well as on the cloud server. Then, of course, as you know, telemedicine is not only about teleconsultation, it is also about tele-education. Now, through the Pan-Africa network, we have liaised with 56 African cities, and we used to regularly conduct CMEs. And we had one of our senior cardiothoracic surgeons, cardiologists, who used to conduct the CMEs along with a panel of doctors. We've done almost 530 CMEs till date. So this was another bucket of I won't say telemedicine, but again, some of the other services which we've rolled out through telemedicine. And then, of course, in the space of CSR, what we did is we collaborated with another tech partner, which was H.P. With H.P., we rolled out both a container model as well as a brick and mortar model, and we introduced EMR solutions and integrated medical devices and teleconsults through that. And we did this in collaboration. It was interesting because we had a hybrid model. For instance, in Rajasthan, we went ahead with the state government. We did it at a couple of places along with Wish Foundation and the state government. And then again, in certain areas like West Bengal here, there are some wonderful NGOs doing great work on ground. So we've collaborated with NGOs on ground. In Karnataka, we've gone solo. We've done single, we've put up our own clinics in rural areas. So we've kind of evolved on our own, So the journey has been that we've looked at various hybrid models and seen how does this technology fit. This has an open EMR, it has integrated medical devices, and we are able to get the data from the dashboard. So it was a bigger move from what was happening earlier in the when we started off with ISRO. It was an improvement on that. And also, the e-health center model was not only about the technology. Technology is an enabler. And apart from that, for us, what was very important was the connect with the community. And so through our outreach programs, we had a lot of community meetings, a lot of screening camps. And we've incorporated now the ICD-10 scoring there. Then we've got a digital prescription. We're able to analyze the disease profiles. So our screening camps are based on what is the disease profile which is arising from that particular area. So that's how, and also we have objective data. So we're able to do prescription audits. So these are the kind of things which we're able to do, at least in the CSR space and telemedicine. And so I'm just showing you some snaps. These are actual snaps of what has been happening across our e-health centers. Some are from Rajasthan, some are from Karnataka. And this was the impact of the program. 64,000 patients have been screened so far. Then we've got specialty camps, which we've just started so far. We've also gotten into curative component. 2 patients, in fact, very interestingly, from our Tikiapara e-health center were diagnosed with ventricular septal defect. They were treated as in Rabindranath Tagore, and it was completely free. So the end-to-end, from consult to the curative component, is something which we're looking at. And then, of course, we've realized that was primary healthcare. What do we do when it comes to secondary healthcare? There are a lot of district hospitals which don't have, they don't have specialists. So there's almost a 60 to 80% vacancy in the number of specialists, at least in the Karnataka healthcare landscape, in the government sector. And so we realized that can we look at a more evolved model? And so we've gone on to other vendors. And they have, so for example, we got a grant from Cisco. And this was again a CSR, kind of collaboration with Cisco, and along with Cisco, through them, not their products, but basically they had other vendors on board. And when they came on board, we got a better EMR. We got like, for example, a SX10 camera with pan tilt zoom capabilities, 10x, between 5x to 10x was the zoom capabilities of the camera. And then, of course, we had integrated devices such as you can see, the blood pressure monitor, pulse oximeter, a digital stethoscope, otoscope, ophthalmoscope. So there was a range of devices which has come in, and it enables a virtual consult. And I can show you a few pictures. It has a DICOM viewer, so it enables for, your CT, MRI images to be picked up. And again, it's a medical grade network, ICD-10 classification, digital class 2 signatures. It was a works, basically. So we've rolled this out also in collaboration with Cisco, again in an outreach model. So we've gone in for certain urban slums, we've gone in for certain rural areas. So that's how it's been working. But the fact is, what I would like to, these are some of the pictures. This was at the launch of the Cisco CSR and NH model. So this is actually the patient endpoint. What you see there in front of Dr. Shetty, that is exactly what will be there at a clinic. So the patient sits in front of the module, and he gets, he's talking to the doctor. So it's almost like a live interaction. What mattered to Dr. Shetty was that we're not seeing a grainy picture of the doctor, and we're not having interruptions. It has to be a seamless conversation. So he was very interested that it should be the visual ambience, which should really count. And then, of course, there was a lot of focus on, the right kind of data coming to us, or at least, so we had FDA-approved devices, so there was no question as to what is the kind of data which was coming to us from ground. And he, in fact, evaluated a patient. His angio was uploaded. He evaluated the angio. He talked to the patient. So it was quite interesting, and this is what has been going on. So that's the dermatoscope. I mean, you would have, I'm sure a lot of people would have seen here, but this is how the top most figure is of how a dermatoscope actually picks up, the photographic image of the skin. And then, of course, what we realized is we also needed some amount of tele-monitoring, especially for ICU patients. We had consultants who were actually the intensivists. We have a very large ICU in Bangalore, and we have very senior intensivists there. Their problem was that, it was getting too stressful, and, to go back and forth the whole day. And so they said that, can you give us some technology which would allow us to also have a glimpse of the patient's vital stats and at least converse with them from home. So we, along with the vendor team who we had brought on board from Cisco, they introduced a simple trolley. So first we came up with this simple trolley. It had issues. It didn't have a battery backup. It was not ergonomically designed, but it was something which was roughly, cobbled together and to serve the purpose, but it worked. And then we went on to a medical cart, which is much more evolved. It's got medical grade casters, a better battery backup. It's going around ICU, so the doctor is able to actually consult. And this is our intensivist. And he is consulting with the ICU right now. So this is how it is happening. He has a DX80. He has his own viewer, which is a PC at home. And from that, he's able to log in, look at the patient, zoom in, zoom out. So he's able to look at the charts. He's able to look at the syringe pump. This is what he wanted. He was very clear. I want to look at it myself. Though he does, of course, depend upon the nursing staff. This is what, based on the physician's, demands is what we had done for him. And then, of course, we have had MOUs with some large PSUs like BPCL and NTPC. Interestingly, like BPCL has retail outlets. And at these retail outlets, what they wanted was that the truckers who come in, they have created this entire conundrum of services, for the truckers. Suvidha, it's called. So they have insurance, they have passport, they have Aadhaar, and then they have this money transfer thing and all that. And along with that, they wanted to put up healthcare. And they wanted a pharmacy also to be linked with it. So they are working on the pharmacy component, and they said, can you come in and can you enable teleconsultation? So we said, okay, fine. And we're working on, so we worked on this model. We've put in the same kind of technology, but we are evaluating whether such a high technology is really needed at a retail outlet for the truckers. It's a simple primary healthcare consult. So what we're looking at is different technologies which would better fit this model. But at the moment, this is what is there. And this is connected to our Jaipur unit. So we've got at Luwara, which is in Gujarat, and Shivdaspura. We are about to scale to another 10 centers, and then hopefully the scale is huge. But so this is what is in the annual for us in the space of telemedicine. A bit about how the DICOM viewer works in the same model. And this is the amount of detailing which can be seen. The doctor can zoom in, and especially for our neurologists, this is a boon, because there are a couple of doctors who consult from, even in Bangalore, I'm sure, I don't know who of you all are from Bangalore, but in Bangalore itself, to travel from one place to another, it's a good 2 to 3 hours. So we've got consultation between our units. So we've got one center, say at Langford, we've got a main hospital in Bommasandra. So we have our Dr. Sharad Damodar, who is a very senior hemato-oncologist. Then we have Dr. Shetty, we have a neurologist, and they consult, and it's easier. So even the follow-up care can happen through teleconsult. So that is also something which is happening. And so what I've tried to kind of, we have several buckets therefore, and we're working on all these buckets. So for example, even if you're to say it's a mobile app, like today we've rolled out a diabetes app, which helps the diabetologist to stay in touch with the patients. Jio'fied, I think, right? So Jio'fied is there, it's evolving. We're trying to introduce such apps for various other specialities. Patient portal is there. What we're trying to display here is the various buckets under which actually NH has dabbled in various buckets. But what we feel going forward would be what we're going to focus on is video conferencing, a remote device, which is what I showed the model, and the patient portal, and as well as the mobile app. So what I wanted to say is that through CSR, and I was also sharing with Vivek sir, we've been able to dabble in various models of telemedicine, get our hands dirty, understand what are the challenges on ground, what works, where are the opportunities, where are the gaps. And that is where then the commercial model of telemedicine has now come in. Ramya from our team, she heads the commercial model of telemedicine, so she would just speak about it. Ramya, please.
So the bottom panel, whatever you see here, the third-party facilities, NH clinics and corporates, the corporates who are interested in having a CSR setup, either in their own premises or probably adapt to rural center, and then we offer telemedicine kind of specialties, be it for primary care or super specialty care, is currently available. What we are looking at and we are working on is the web-based and the app-based consults of NH, and the kiosk-based things wherein the person steps in the height, weight, and whatever basic parameters are taken, and then he does a primary consult. Portable telemedicine kits wherein specialty-based consult can be done. And in reference to the corporate space, it might be a PSU like an NTPC or like a BPCL or any corporate like a HCL or whichever is looking into it. So right now what we have is the primary and secondary care. Secondary care basically includes all the super specialists, be it a diabetologist, endocrinologist, cardiac surgeon, wherein post-surgical kind of care takes place, the wound care and those kind of things happen in the secondary care space. We also do preventive care checks in it, and the tele-ECG facilities which she has already covered. The second opinion part of it is happening, and the tele-ICU part of it. I'll show you pictures of what has been happening in this space. And the proposed one is extend the primary and secondary care, the health checks and diagnostic services, the remote ICU care. You saw the cart, right? So we're extending it to the emergency and the dialysis and the ICU part of it. And there's a lot of query which comes to us, basically from the corporates, wherein they say that you have their dependents who are staying in India, whereas these guys are placed abroad, and so they need to have the entire detail of the patient's history and everything, the family history of who is having what disease and what is the prognosis and what is, if they have undergone surgery, what is the how are they progressing and what are the medications they are on, and the kind of questionnaires that they answer varies from cardiac, diabetic to psychiatry or whatever it is. So everything is, we have got it under one portal, so you sit wherever you are, you have an access, the entire family's medical records, everything is available, and you go to a hospital, you do a consult, you do x-rays and CTs and whatever, everything is pushed back to this portal so that the patient can view it wherever he is based. And we have a care companion program, an interesting program which runs out of right now at a hospital in Bangalore and Arctics here in Kolkata. wherein the patient attenders are trained as to how you take care of the patient post-surgical thing. So right now we are doing it over a call wherein the doctor and the nurse follow up with the patient regarding the wound and how he is progressing kind of thing. So we are planning to take it to the telemedicine mode of it, so that the readmissions and the infections kind of thing come down. And also we are looking at the EACMAs part of it, wherein we put telemedicine kiosk in tier 2, 3 kind of areas and conduct CMAs sitting out of tier 1 town. So what are the telehealth capabilities? Right now we are offering as telehealth, the vitals, whatever can be seen, the ECG part of it, the live video stream which can be done, the SETH part of it, the medical history, the tele-ICU, DICOM support, prescriptions. As she said, we have digital class 2 signature which is enabled for the doctors who prescribe, and this prescription the patient can take a printout and this is valid. We have lab devices. Looking forward, in another few months we will start the telestroke and the telepath facility also. So when you see a telemedicine kiosk, this is how it looks. It's a big 43-inch screen, and then we have a 21-inch screen where the nurse is able to enter all the vitals, though the vitals is like all the devices are Bluetooth enabled, so it seamlessly, when the check gets done, the nurse has to press enter and all the vitals just gets displayed in it. So these are the devices which are integrated in kiosk. The ECG, portable ECG, pulse ox, spirometer, glucometer, and the BP monitor, the multiparameter which does some 8-9 tests, digital stethoscope, and the low-end video scope set. Plus we have the high-end video scope set for the otoscope and the dermatoscope kind of a thing. The ultrasound also can be done. The X-ray digitizer, pathological microscope, and are not yet enabled yet. And the weighing scale, we do a manual thing instead of a Bluetooth thing because the cost. Really it's very expensive when compared to having a economical one. So if it's like a secondary care of model, we don't mind using the Bluetooth enabled, the weighing scale kind of a thing. But if it's a primary care, we have cut down the cost drastically and see which kind of model suits where. Otherwise, it's like a lot of investment for a primary care model. When you see the nurse and portal in a telemedicine thing, the nurse can create appointment, connect to the doctor, the vitals can be captured, the ECG sharing, everything is done live streaming here. Stethoscope, file sharing, DICOM sharing. Once the doctor prescribes after consulting the patient, prescription printing happens at the same place. And we're looking at for primary care centers wherein we have the ATM kind of dispensing thing for the pharmacy, wherein 62 basic drugs are loaded into the ATM dispenser, and then with a QR code you scan and then deliver the medication to the patient. So it's like a one-stop place where the patient need not go to a pharmacy in rural areas. This basically, our tier 2, 3, it kind of helps. The doctor in basic, it's very simple, which has got a laptop or a desktop and even a tab kind of a thing. Right now we are doing teleconsults within NH, wherein Guwahati, Delhi, Jaipur, Mumbai, Bangalore and Kolkata will be the hub hospital, and the rest of the other hospitals that we have out of the 25 will be the spokes. We do specialty-based consults, like we have tele-psychiatry services, tele-cardiology, or the oncology part of it, wherein we find that there are no psychiatrists available in certain units, whereas Health City has, be it child or adult pediatric, pediatric or adult psychiatrists who are available, plus counseling which needs to be done. We connect to Health City with a specified timing, so that based on whatever the region is and the doctor is able to converse, we connect to the respective doctor. We also offer specialty-based consults, surgical advice, and follow-up and second opinions within the NH network. So when you see the models, the primary care model, this is in one of the PHCs. This is how the live consult happens, where the patients are seated and there is a nurse at the other end. And then you have patients who are waiting outside, who are enrolled and waiting for their turn to consult with the doctor. We put these kind of primary care things in places where there is no access to primary care and patient is not willing to travel for basic cough, cold kind of a thing. They can consult right from this place, and the doctor, we basically connect to the respective hub. Like if it's somewhere near Shimoga, we connect it to Shimoga, so that in case a patient needs a secondary care or any other super specialist advice, they can travel to that place. Okay. So we'll be rolling out the community-based healthcare model. This we find it useful when a lot of corporates, like I told you, there are a lot of corporates who are looking in for. I'm just rushing through the slides. This is basically a portal wherein the patient, when you have an appointment, you have a doctor calling in, so you have to just accept and you just connect with the doctor. Educational material, whatever needs to be done, gets uploaded. And the system becomes complex when you are connecting to multiple people. So you need a care coordinator who will tell you that, okay, you have a gynae problem or a pediatric problem, or you just need to meet a general medicine or a diabetologist or physician. They manage the queue and connect you to the respective doctor. This is how it works, and also gives you the geographical location as to where the patient is connecting from. This is a portal for NH wherein both the patients and their relatives and we can have, I mean, whomsoever you want to have access to, the physician also the other end can access. This is how the dashboard looks. Your daily vitals, if you're having home monitoring based Bluetooth enabled devices or manually which needs to be entered, this is the kind of, like you can enter the date and time when you have taken your BP and and save it so that it's easy for the physician to go through the history when you're meeting him the next time. The physician portal kind of a thing, he can search for the patient either through the name, the surname, or the date of birth kind of a thing. This is how our physician portal works. The specialty based consults, I think based on what is the need, it will be either endocrinology or diabetology or cardiology. Based on the need, we offer this kind of consults. As Dr. Shetty consulting, ICU monitoring. This is in one of the Health City where the doctor, the intensivist is consulting with the other intensivists who's based on a different place. I think I'll come to this slide, which is more important. What works in telemedicine? You need a program manager who will drive end-to-end, connect with operations, the IT, get the vendors on board. You analyze which kind of telemedicine software, what are the different medical directives. You need an FDA approved device for secondary care kind of a thing, or for primary care, the BIS kind of certified devices is fine. You need to identify the right location where you have to put, and identify the model, whether you want to test with the rental model kind of a thing, or you go on for a OPEX model. Training of the paramedics, whoever will man the nursing end. Recruit localites, which will add more flavor because they will spread the word, and they can do home to home kind of free screening with the basic baseline screening, whichever needs to be done, and ensure there is good connectivity. Recruit young and energetic people who are tech savvy, who will take it and go that extra mile to deliver things. And we need to have set goals and review every now and then, and so that we ensure we reach what is our target, ensure sustainability, and most important thing, have feedback with reference to the experience both from the doctor end as well as the patient end, so that whatever changes needs to be done can be done. And the most important thing, the last but not the least, is audit every now and then at both the nurse and the doctor end, and keep training people and add based on whatever is the community requirement is, based on the disease profiling, whatever is. I think I'll end with this.
Thank you so much. Can I please invite Dr. Vivek Desai on stage to felicitate Anupama and Ramya? Are there any questions from the audience?
I think we kind of rushed through the slides also. There was quite a bit. But
You said about OPEX model.
Yeah.
Is that investment done by you?
Yeah. If it's anything related to. Yeah.
And how much it costs to put one second?
It varies. That's what I said. If you're looking for a secondary kind of a consult with FDA approved kind of devices, you go up to 10 to 11 lakhs. Otherwise, 3.5
Let's
lakhs.
talk slowly now.
Okay. Otherwise, 3.5 lakhs is the minimum requirement wherein you have the.
This is important for us to hear. 3.5 lakhs. That's not very expensive.
It depends. Yeah, it depends on the vendor. So, and the kind of
One
service.
question, which actually not mine, but Dr. Bhu's. Why can't we use a handheld device rather than going through all of that?
Yeah, we can use handheld devices also.
Is WhatsApp?
I skipped those slides actually. So.
No. So the feeling is that if you use WhatsApp, is this required?
No, WhatsApp. I mean,
doesn't
the
have
kind
security
of,
features is
yeah.
what we've been told by the legal team, sir, as per Information
the
and
kind of
Technology
data what
Act.
you have in this app, where the patient, the history, everything is available, right? This you can't reproduce the WhatsApp conversation what you had.
We'll look at
How do you monetize the entire?
We have recording of each and all the sessions.
How do you monetize it?
Monetize it.
We basically went in for a rental model first for 6 months, studied what works, and then we went in investing in capex across different units. We have not gone ahead all with all the 25 locations. We have done it with 4 or 5.
System that you devised harvest patients for the main hospital and for second opinions.
It's mostly for second opinions.
And
right?
like I told you, like
Also
a care
follow-up
companion
cases.
program I was telling you, the nurses and the doctors usually call and then find out whether the patient is following the routine and the lifestyle, the medication kind of a thing. Through teleconsult, if it's near to his home, instead of traveling to Bangalore or Kolkata kind of a thing, he'll go to the nearest like the Shimoga, Sirsi kind of location.
Information.
Wearable devices,
No,
I
so
mean,
we
we
are
not-
exploring that. You know, for example, our diabetologist, he's come up with Jio'fied an app, and he's exploring wearables. So there's a lot of work which is happening. Even IoT, I didn't mention IoT right now. So we are incorporating IoT in our ICU model. So you know, so that there is real-time kind of data which streams in, and all this is then available to the consultant. It's actually an upgrade on an existing module which was developed internally by us. It's called iCare. We did it with Cognizant. And now we're going on to the second version. So the iCare second version will have an IoT enablement. So at each bedside, I think they will be placing these devices, and there'll be a live streaming. It will help in reduction of the nursing administration time, you know, all those things. So,
and the data.
yeah, but that's a separate.
Yes,
which one?
yeah, we have just.
Yeah, this is a separate vertical. It's a separate vertical in itself. So, yeah. So the challenge for us is we realized when I started off in CSR, we didn't have a backbone, you know, as such. We don't have a pool of specialists or a pool of, say, MBBS, even consultants who can take these consultations, you know, on a regular, systematic basis, you know, scheduling appointments. So for her, the whole work was really
And mostly
set
doctors
out.
give us during the lean time. Okay, Thursday 3 to 5 I'm free, so that time you take for teleconsult.
It doesn't
This
work
is
that
for
way.
me. So I had to tell doctors like, no, Thursday is already booked, so you give me a different slot. So if I'm connecting Shimoga to Health City, and all the doctors give me Thursday 3 to 5, the rest of the specialties how will I cover? So
So a lot of challenges are there which we've learned from.
Okay, thank you.
Thank you, sir. Thanks.
can I?